it's my absolute great pleasure to introduce Dr. Justin Strickland. He did his bachelor's degree at Davidson College, where he wrapped up in 2014 and moved on to the master's and PhD program at the University of Kentucky, and worked there with someone we know here at the center who has presented and interacted with us on a number of occasions, Dr. Bill Stoops. And then he went and did a postdoc starting in 2019 at Johns Hopkins University, where they very smartly hired him as an assistant professor in 2021, and he is there at the School of Medicine. I'm tired. I'm very, very tired. Like, his productivity is unbelievable. He has published over 130 papers, reviews, and chapters. Did I mention he finished his bachelor's in 2014? I'll let you do the math there. His productivity and impact has been amazing. In fact, I was looking at his collection of reviews, and I think I actually think like I might do a graduate class around these review papers, because the topics are absolutely amazing and require an amazing breadth. So the very first review paper he published was the effects of social contact on drug use, behavioral mechanisms controlling drug intake, and the most recent one in press was behavioral economic demand, how simulated behavioral tasks can form health policy. I will say he's also a PI and a co-I on numerous grants, including from the NIH, National Institute on Drug Abuse. He also reviews quite extensively for NIH, other journals, serves on the board for many key journals. I know I have the privilege of knowing Justin personally. He's a very generous individual, very kind, thoughtful. He gives freely to discipline, to other scientists. Most recently, I've worked with him on the executive committee for Division 28 of the American Psychological Association. He's just always giving back, so much appreciated. The one thing that makes me sad about this talk and that we do this virtually is that he's not here in person, because then I would ask him to join this old gray beard and go for a run, because he is an avid runner. And he's inspirational in that role as well. This morning, he clocked a 21-mile run at a 7:40 per minute pace, an absolute inspiration. With that, it is my absolute pleasure to introduce Dr. Strickland, and today he's going to talk to us about behavioral economics and substance use public policy. So thank you very much for joining us, and we look forward to hearing what you have to say.
Thanks, Rick. And I promise that's not a usual day. I'm on the tail end of a training cycle, so that's not a usual Thursday morning. Thanks you all for being here. As Rick said, the chat will be open. I'll try to keep an eye on it. I'll try to answer questions as they might come up. But if I miss it, I'll catch it at the end, and certainly leave plenty of time to answer some questions at the end. So I was thinking about what I would talk today, and I figured that this topic would kind of hit on a little bit of everything for everyone, a little bit of preclinical work, a little bit of clinical work, and a little bit in public health and public policy. So today I'm going to talk about behavioral economics and substance use public policy. Don't let the title mislead you. I'll kind of talk across a translational spectrum. I do disclosures. I just receive support from these groups and no relevant conflicts of interest. So Rick kind of already went through this, but before I get started, I wanted to trace a little bit about what I've done to inform where I am now and the research that I do, because it does emphasize this translational perspective for research and the importance of a translational pipeline in what we do. So as mentioned, I went to undergraduate at Davidson College, working with Mark Smith there. Very early on, got involved in rodent self-administration work, primarily within the realm of social context and how social context can influence drug-taking behavior. And this work looked at various features of social context, one of which in the first paper I was involved with harkens back to what I'll talk about today in the context of behavioral economics, showing how it's not only the access to a peer that influences drug-taking behavior, but the drug-taking nature of that peer. Such that a drug-taking peer, in this case a drug-taking rodent peer, facilitates drug-taking in an animal, whereas access to a non-drug-using social peer inhibits that use. Also at the time in my thesis work there, centered around the role of exercise and substance use. Kind of ironically, at the time I did not run, so there's this kind of interesting research leading us to what we do later. And my work there is centered around the role of resistance exercise specifically. And so early on, working with these sort of econometric and behavioral economic analyses that I'll talk about later today, showing that in rodents engaging in resistance exercise, we see this increased sensitivity to price for cocaine self-administration, indicative of a therapeutic effect. Now, of course, also as mentioned, I then went on and translated that work in my graduate career and graduate studies into the human laboratory, working primarily with Dr. Bill Stoops. And these studies primarily involved residential human laboratory research, where we evaluated novel pharmacotherapies for cocaine and other substance use disorders. And there I also began to weave in this and carve out my own niche in this world of behavioral economics and the application of economic principles to understand drug action as well as therapeutic response. Unfortunately here, we saw very little effect of a novel therapeutic, phendimetrazine, but we're able to apply this method in that context. And then finally, as mentioned, I back in 2019 began a postdoc and now I'm a faculty member at Johns Hopkins, working with other folks in the Behavioral Pharmacology Research Unit, or BPRU, Matthew Johnson, Ryan Vondre, Kelly Dunn, Elise Weertz. And in thinking about kind of, again, along this translational spectrum, how can the work that we do in the laboratory, in the both preclinical and human laboratory, translate to public policy that matters in a broader scale, to the FDA, to regulatory action. So just as one brief example, have done some work looking at reduced nicotine cigarettes and their substitutability, something, again, I'll talk a little bit about today, for full nicotine cigarettes. The FDA gained control in 2009 of tobacco and regulation of tobacco. And there's been this policy that's kind of kicked around over the last 10 years or so with action to reduce nicotines to this minimally addictive or minimally abuse liability level. And then, of course, like many of you, a lot of my research hit this kind of weird impasse in 2020 with COVID, but thought about ways that I could apply what I was doing to understand the COVID-19 pandemic and understand how these procedures that we use in addiction science and substance use policy can apply more broadly. So here are just some data looking at demand curves for COVID-19 vaccines. These were collected back in August 2020, before we had a vaccine. And we followed up with these people later. And as you can potentially see, we saw this clear differentiation as a function of the likelihood of later getting a vaccine, giving some credence to the ability of these sorts of tasks to predict future behavior. I promise I won't go through data as fast as I did there, but I just wanted to give you a little bit of background of kind of where I'm coming from and thinking about how we do research across this translational spectrum, and how even when we kind of are hearkening back to preclinical laboratories, that those in this translational step can have a clear public health impact along this pipeline. So when we do our rodent work or preclinical work, when we're working in the human laboratory under simulated environments that, while they're not identical to the outward world, are modeling them or simulating them in some meaningful way. And then, of course, at the epidemiological level, understanding how the things we roll out impact and shift substance use patterns and other patterns in the general world. And so what I'll talk about today and really focus on is how behavioral economic demand, a key principle in behavioral economics, can be applied across this translational continuum and can be applied in a way that impacts public health policy and has the potential to expedite what we're doing at a public health level to address issues of substance use and substance use disorder. Here's just a schematic I'll return to later from a paper with Derek Reed out at University of Kansas, looking at this kind of translational step. And I'll break down some of these pieces after I talk about kind of various steps today. So today I'll talk a little brief history of behavioral economics for those of you who are not familiar, in particular not familiar with the flavor of behavioral economics that we think about in operant psychology and substance use research. And then I'll kind of hit three key areas of this translational continuum: preclinical models, human laboratory research, and more public health impact guided or public health facing research. So when we talk about behavioral economics, there's, at least to me, very much two flavors of behavioral economics. The one many of you are probably more familiar with is this behavior of economics. So this is how economists have thought about the advances that have occurred in psychology and applied them to understand things like framing effects or nudges, popularized by folks like Daniel Kahneman or Richard Thaler, and this way of applying these, these psychological principles to explain economic decision-making. Apologies, let me take a sip of water. Those 21 miles did me in, I guess. We can also think about the economics of behavior. Apologies, one second. Okay, we can also think about the economics of behavior. So this is thinking about how psychologists have applied economic decision-making or things we know from econometrics to better understand behavior and decision-making for public health and public issues of public health significance. So thinking about things like the impact of cost or the impact of alternatives or the impact of delay to reward. And this economics of behavior is the kind of the main thrust of what I'll talk about today. This is certainly nothing new. This harkens back to, at least to the 1980s and 1970s, with luminaries in the field, folks like Steve Hirsch. And apologies if folks can't hear me. I'll take a second and regain my speaking voice. We're talking about losing voices on the call before this. I lost mine a couple of days ago, and that seems to have come back. So this harkens back to folks like Steve Hirsch, others who applied these economic concepts to operant behavior and the experimental analysis of behavior back in the 1970s and 80s. And you can see just one of those examples here, and many others, folks like Warren Bickel, J. Lee Tucker, Howie Racklin, and how we can understand operant behavior and other aspects of the experimental analysis behavior by incorporating economic principles. And so the main idea I'll talk about today is this decision-making as a over or under valuation of outcomes, or what we often refer to as behavioral economic demand. At a very simple level, demand or behavioral economic demand, I'll refer to it demand most of today just for the sake of brevity, is the systematic relationship between the price of a good, often plotted on the x-axis, and its consumption, often plotted on the y. And what we generate from these analyses are demand curves, which describe this negatively decelerating consumption as a function of price. And the benefit that we get from this demand curve approach to understanding reinforcement and valuation is it separates different aspects of reinforcement into these functionally and mechanistically specific aspects. And so we can think about, for example, Q naught or demand intensity. This reflects the consumption of a good at its unconstrained price. So for example, the all-you-can-eat buffet, how much of a good are you consuming when it's free or functionally free? as well as elasticity, which represents price sensitivity. Now, when we talk about elasticity or this price sensitivity or sensitivity of consumption to changes in price, we can talk about aspects of a demand curve that are relatively inelastic or insensitive to price, or elastic portions are relatively sensitive to price. And so often an example of an inelastic good is something like gasoline. As gas gets more expensive, we don't really change our consumption of it all that much. We just pocketbook hurts more. Whereas something that's very elastic in its demand is something like candy. When candy gets expensive, we just stop buying it and our consumption greatly decreases. Now, a point I always like to emphasize here when introducing this concept of elasticity and inelastic or elastic demand is that this is nothing intrinsic to the good itself. Gasoline itself is not an intrinsically inelastic good, nor is candy intrinsically elastic. It's this dynamic interaction between the good and its environment and the person that determines that relative inelasticity or elasticity. So what do I mean by that? So for a small child, something like gasoline is not going to be an elastic good. It's going to be highly elastic. Whereas on the other hand, that candy is probably going to be a pretty inelastic good. So that elasticity is not determined by some intrinsic nature of this good is higher in its elasticity or lower in its elasticity. It's this dynamic interaction between the functional need that that good is serving for the given person we're measuring it in and that certain context. And so how can we apply these principles of behavioral economic demand to give insights at the preclinical level? So much like money can be thought as cost, we can think about things like operant responses, things like nose pokes or lever presses, in very much the same way. And we can generate these same sort of demand curves, these same negatively decelerating curves plotted as a consumption of a good by its price in the preclinical laboratory. So here we're looking at an example of that same sort of demand curve where we're plotting consumption of cocaine on the y-axis as a function of its cost. In this case, the number of responses needed to receive 1 milligram of cocaine. And what's nice is when we look at those same demand curve metrics, alpha or elasticity, as well as Q naught or intensity, we see that they relate to other measures or other models that are thought to be clinically or prognostically relevant, things like extinction responding or primed reinstatement or cued reinstatement or sensitivity to punishment, suggesting that these metrics on a demand curve are tapping into something likely functionally or at least prognostically important in our preclinical models. And so in some work with Ryan Lacey, Ryan was a postdoc at Davidson when I was there, and we've continued to collaborate since. He's now up from me at Franklin and Marshall University in Pennsylvania. So we looked at these demand curves for two drugs, cocaine and remifentanil, in rodent models measured over a 15-day period. And so what we found first and foremost, we also looked at sex differences, so female and male rats. So what we found and what was to date mostly undescribed is that these demand curve metrics after a couple of days are fairly stable in a rat that's not otherwise undergoing any sort of other environmental or situational manipulation. So we see this fairly stable level of both that unconstrained demand or demand intensity, as well as elasticity. Now, what this paper did and why I bring it up today is it gave us the opportunity. So these determinations of both cocaine and remifentanil. Remifentanil, for those of you who don't know, is a very short-acting mu-opioid agonist. So the fentanyl route probably gave you that hint, but it's a very short-acting opioid. So we determined these curves in both of cocaine and remifentanil in the same subjects. And so what that allowed us to do is see the concordance of how exposure to one of the drugs impacted intake of the other. And so in a cohort that had no history of remifentanil, so the cocaine was determined first, we found that the later remifentanil intake had very little association with cocaine demand. So in other words, the general propensity to use opioids later was not related to the amount of cocaine used in these subjects when it was determined first. In contrast, when remifentanil was tested first, we found that there was this clear and stepwise relationship, such that greater exposure or greater drug intake for remifentanil led to this enhancement of cocaine self-administration. This was reflected both in the top in this demand intensity metric, where we see this stepwise increase in demand intensity, as well as in this demand elasticity metric. I hinted at it, but just to emphasize, higher values for elasticity are good. It means that the good is more price sensitive. There's a greater decrease in drug taking with cost. So in this case, lower values indicate these animals had a less sensitive consumption to price, so they continued to take cocaine despite an increase in cost. So why do I bring this up? Why is this relevant? For those of you that are unfamiliar, when we look at rates of stimulant use, and specifically methamphetamine use over the last 5-10 years, we're seeing this precipitous increase amongst people that use opioids. Specifically, we've seen this jump in methamphetamine use from about 9% of people that have used heroin in the last month also used methamphetamine back in 2015 to about 44% in 2019. And that's held fairly stable in the years since. These are data from the NSDUH, which is our kind of standard epidemiological source. And this is not just a general increase in methamphetamine use amongst everyone in the US. So if we look at people that use cocaine, co-use with methamphetamine has remained largely stable, hanging out around this 9-10%. And we see signals of this in other sources. So in some work with Jennifer Havens, Jen is back at University of Kentucky, epidemiologist and biostatistician extraordinaire. She's had this cohort of folks that has been followed in Eastern Kentucky since 2009. At the time that they were recruited, they were primarily prescription, non-medical prescription opioid use dominant and recruited for that reason. And as you can see in this graph, over the last 10 years, there's been this shift in the epidemiology and the profile of use, such that there's this huge uptake in methamphetamine injection drug use. This corresponded to this decrease, although part of this is a co-use of non-medical prescription opioids. And Jen has done some really interesting work qualitatively teasing apart why this might be occurring. Why is there this shift in substance use patterns of towards this polysubstance use of stimulants and opioids in this cohort itself? And the major themes that came up in this qualitative work was that methamphetamine was functioning to mitigate some aspects of opioid withdrawal. It was serving as a cheaper substitute for heroin. It was providing this synergistic high. It was perceived as a safer alternative following spikes in opioid overdose fatalities. And so I find this really interesting as someone who thinks about behavioral economics, because each of these all speak to functional relationships that we can glean out of these same sort of demand curve analyses. What do I mean by that? When we focus, I focused so far today on this red or orange-ish circle. And so this is demand curve measured in isolation or measured without consideration of other commodities in the environment. But goods intrinsically and inherently interact in a meaningful way. The availability of alternatives can dramatically change the extent to which a good is of value or a good is of interest. And so we can think about these same sort of demand curves in this cross-commodity way. And so on the top curve here, we're looking at the consumption of some good that's being manipulated in its price, as well as another good that's being measured at a fixed price at each of these changes in the cost of the manipulated good. And so what we see here is, as we would expect, as price goes up for this red or circle commodity, it systematically decreases. We would expect this. We would expect nothing less. But when we look at this fixed cost good, we see that as the price of the red circles go up, these blue hexagons, their consumption goes up. And this suggests that they function as a substitute. In contrast, when we look at this one, we see that the price generally decreases, or the consumption generally decreases, suggesting it functions as a complement. Put in kind of more lay or clear example terms, the top here would be Coke and Pepsi. You may not like Pepsi as much, but if Cokes were $20, you're certainly going to drink the Pepsi. It's going to substitute for it. In contrast, here is your hot dog and hot dog buns. As the price of hot dogs go down, or as goes up and your consumption goes down, you're not going to buy as many hot dog buns. You still may buy some to put like hamburgers on in a weird cut up way, but you're certainly not going to buy the same amount you did before. They complement one another. And then of course, goods may not interact in a meaningful way. So if we go back to the examples here, when we think about these rationales, serving as the cheaper substitute, that one's pretty obvious. Synergistic highs, that's this complement fashion. A safer alternative, that's this substitute fashion. Cost doesn't just have to be price. It can be things like the mortality cost or the danger cost. And so we may be seeing this sort of spike for these kind of myriad of reasons. And so we have some work planned. Hopefully we're on the precipice of getting this off the ground, where we're going to test this in a experimental setting. This is my nice segue to the human laboratory, where we can test this interaction between opioids and stimulants, specifically opioids and methamphetamine, and a human residential design, where we're looking at under blinded conditions, how are these drugs pushing and pulling one another, and how are they functioning, for example, is methamphetamine functioning more as a substitute or a complement, and for whom that might be the case. And this has downstream treatment implications, because the way that a drug is interacting with another when someone presents with a polysubstance use pattern dramatically changes how you treat that. You can imagine if it's functioning as a substitute, if you're treating one drug, the other one's only going to spike up further, versus if a drug is functioning as a complement, they're going to go down together. There's, of course, some medications development, cool stuff layered into here that I won't get into now, but I'll get to in just a moment, talking about the human laboratory. So that was a little bit about the preclinical laboratory. I sprinkled in a little bit of the trace and the pipeline to how we get to public health significance in public health translation. But when we talk about the human laboratory and conducting behavioral economic work in this setting, we can port many of the same procedures that we might use preclinically directly into the clinic. So this is a photo from one of our smoke box rooms. We have 4 ventilated rooms where we can conduct combustible cigarette and other vaporized product drug administration sessions. And what you see here are program boxes where we can measure that same sort of fixed ratio response we might in a non-human subject, vary fixed ratio requirements here on the x-axis, and measure the number of reinforcers received on the y. And lo and behold, when we do that, we can generate these same demand curves. We do in the preclinical setting in a human operant or human laboratory setting. Now, the drawback to this approach is each of these data points requires a whole day's worth of data collection, a whole day's worth of someone coming in to the laboratory, collecting information, completing fixed ratio responses, the whole kit and caboodle. And unlike the preclinical laboratory, our participants don't show up as reliably. And so this can take a lot of time. It requires specialized equipment. It requires a lot of personnel effort. So it's burdensome. And so our approach that we've taken and others have taken to complement this more intensive operant approach is something called the simulated purchase task or purchase task procedure. So this procedure relies on verbal behavior manipulations, presenting participants with a vignette describing some sort of context. In this case, we're measuring alcohol demand. So presenting them with the context of, imagine you're out drinking, you can buy as much alcohol as you want over the next 24 hours. It's going to cost various prices. You can't stockpile or sell it. So we're really just interested in your consumption now. And then we ask across a various set of prices how many standard drinks they would purchase. And what we get from this is a very similar systematic demand curve as what we might get from conducting that operant approach, where we see this relationship between the consumption here on the y-axis and its price on the x-axis can generate those same metrics, Q naught and elasticity, as well as other features of the demand curve. And importantly, when we compare these or associate these with measures of quantity frequency or severity of substance use, we see this association between these things, suggesting that they're tapping into something about the person and something about underlying substance use susceptibility or stage of substance use disorder that's of some clinical relevance. And so I mentioned the purchase task because it allows us the opportunity to, in a way that complements what we do in those more traditional operant ways, expedite targets of research and expedite discoveries that might happen in the context of human laboratory research. So I'm going to talk about one example of that today and hopefully convince you of the merit and value of in which we supplemented a traditional drug self-administration study with this purchase task procedure approach and kind of the hints of and the signal that we get from that. So this was a study looking at suvorexant. Suvorexant, for those of you who are unfamiliar, I'll go into a little bit of the neurobiology. If you're not interested in this stuff, you can kind of check out for a second. Suvorexant is a dual orexin receptor antagonist. The orexin system is really interesting because it was only discovered about 20 years ago, also known as the hypocretin system. Two groups discovered it at the same time. Orexin was the name for one group, hypocretin was the name for the other. Orexin has more or less taken over as the dominant name, but you will sometimes see it referred to as hypocretin. And it seems to be the system that has this kind of master switch or key regulatory role in regulated behaviors. There's a lot of innervation in the hypothalamus and projections from the hypothalamus. So any of these homeostatic behaviors seem to be regulated by the orexin system. The currently FDA-approved compounds, suvorexant, limborexant, doridorexant, there are dual orexin receptor antagonists, are all used in the clinical indication of insomnia, so implications in sleep. As you can maybe see in here, there's also important projections to the VTA and our other kind of key canonical areas of drug reinforcement and drug use. And the fact that substance use is a motivated behavior in this kind of homeostatic balance, or lack thereof, has led to the suggestion of the role of suvorexant and clinical relevance potentially. So here you're seeing some preclinical data showing decreases in cocaine self-administration with systematically with increases in suvorexant dose. And so I should note this is was a study led by Bill Stoops, who I've mentioned already, that had kind of kicked off as I was leaving Kentucky, but they were nice enough to let me include some of my purchase task stuff and other measures in there. And so what we're looking at here is a purchase task demand curve that was generated for the blinded drug that was administered in the study. So in the study, oral suvorexant was delivered at doses of 0, 5, 10, and 20 milligrams once daily at its clinically indicated time of 10:30 p.m.-ish, so before bed, at least 3 days on a maintenance dose, and then intravenous cocaine was measured at 0, 10, and 30 milligrams per 70 kilograms for drug self-administration data I'll present in just a moment. Now, we leverage the fact that at the same time we could be collecting these demand curves for that blinded drug, so participant doesn't know it's 0, 10, or 30 milligrams. But we can ask, how much of this drug would you purchase if you're out in the real world and you had the opportunity to use it? And so first, if we're just looking at placebo responding, so this would be responding for saline that was infused. Fortunately, we see very little of this, so very little placebo responding. In contrast, when we look at this 10 milligram intravenous cocaine dose, what we see is this very systematic and dose-related increase in cocaine demand. You may have heard me say increase, which is a very unfortunate thing to say for a medication. So what we're actually seeing is this inverse from what we might expect, where systematically we're seeing this stepwise increase from 5 to 10 to 20 milligrams of demand for cocaine across the different suvorexant doses. In a similar story at the 30 milligram dose, albeit a little bit less clearly dose related, although again, this increase under the active relative to placebo doses. Put another way, which is some of our metrics of demand curves, Pmax, breakpoint, and Omax are a bit more simplistic ways of representing that elasticity metric. But what you see across the board is this upward shift in the demand curve, or in these metrics under the active suvorexant doses. The benefit that we get from that purchase task approach, though, is we don't just have to measure drug self-administration for cocaine. We can also look at other targets that might be of interest. And so, for example, we looked at alcohol demand under an alcohol purchase task procedure. And what we found was a similar-ish story where we see this stepwise from 0 to 5 to 10 to 20 milligrams increase in demand for alcohol following the cocaine self-administration context. And again, looking across these facets of demand curve, this kind of upward shift. Now, this would seem completely paradoxical and completely against what the preclinical literature has shown, and against kind of what we would expect. And I would maybe write it off as a methodological problem, with the exception that when we look at the actual drug self-administration, drug choice in a concurrent progressive ratio task, we see an almost identical story where we see this, albeit a little less dose orderly, but this increase in cocaine demand, a significant increase at this 10 milligram dose of suvorexant, increase in drug choices under the active suvorexant. So largely corresponding to what we see in these demand curves. And so there's a few explanations for this. I won't go too in depth to them, but I think it's important given the contradictory nature of both of these findings. Most of the preclinical literature looking at suvorexant has looked at it acutely, so in the absence of chronic dosing, and B, has only looked at it as an immediate dose given before drug self-administration session and not at its clinically relevant time at nighttime. It's a sleep medication, so you take sleep medications before you go to sleep because they have sleep onsetting effects. And for the behavioral pharmacologists in the audience, this seems like a really obvious disconnect. We know the acute effects differ from the chronic effects, and that motoric effects or off-target effects can, of course, impact drug taking. But there's been kind of a lack of correspondence with those preclinical models of what we might expect translationally. So I don't think a failure of translation here as much as a potential lack of correspondence of the majority of the preclinical studies with what we might expect clinically. I'm starting to run a little low on time, so I don't have too much left, but I'll be brief here. I've talked a little bit about the preclinical laboratory. I've talked about the human laboratory and how each of those can kind of take stepward paths towards clinical and public health significance using these demand models. And I'll talk a little bit more about that kind of more direct public health impact. So I've given one example with that trajectory of understanding stimulant and opioid co-use. A really great paper here from Michael Amlung, also out at University of Kentucky, or sorry, not Kentucky, Kansas. Although go Kentucky in the upcoming tournament. So this paper was looking at this same sort of drug substitutability complement approach to understanding the impact of a legal cannabis market on illicit or black market cannabis consumption. Because we have this really important problem when thinking about cannabis regulatory pathways of ensuring that the illicit market is maximally priced to reduce adolescent consumption or young adult consumption or consumption in an unregulated way, but minimally priced so that it can compete with gray markets and black markets and shift towards the safe supply that occurs in illicit market. So looking at how you can optimize pricing structures to do that. Another paper here, again from Derek Reed, showing the impact of happy hour pricing structures, buy one, get one free, and half price drink specials, and how that changes consumption or at least simulated consumption for folks. Derek has talked to me about how there's actually remarkably little research on, at least experimental research, looking at this. And he's been called up a number of times as states and jurisdictions think about implementing or removing half price or happy hour drinking specials. The take home being here that particularly buy one, get one free drinking specials can greatly enhance alcohol consumption relative to full price specials. Well, full price, not specials. The more kind of recent, or the thing I'll talk about in this context today is a study where we conducted a daily diary study, daily diary studies collecting alcohol consumption on a daily basis. Here you can just look at consumption across a 18-week period where we looked at daily drinking or heavy drinking. I like this graph as a steward of the behavior analytic tradition, because it shows when you graph up your data, you see interesting trends. And here it's the weekends, not surprisingly, have these kind of clear cyclic spikes in drinking. What I want to talk about, though, in the case of demand is this impact, coming full circle to some of the social environment research I discussed earlier, of the impact of the social environment. So this was some work done with Sam Acuff. Sam is currently up on clinical internship at Brown, about to start a postdoc at McLean. And Sam and I looked at this impact that the social context can have on heavy drinking behaviors. And so what you find is when folks are drinking in isolation, you see folks that on average drink more in social contexts are less likely to be have a heavy drinking day. So put another way, when you compare across people that drink more when they're alone tend to have higher or more alcohol-related problems. But in contrast, when you look at the momentary event and when you look at the actual social context event, you see the opposite direction effect. So when someone is in a social context, they're more likely to drink heavily. So what we see is this ecological fallacy or paradox, where the direction of the effect of social context differs if you're thinking about a between versus within person effect. What does this have to do with behavioral economics, though? We also looked at the person level, whether they were more inelastic or elastic drinker, and found that social context, that momentary effect, more dramatically impacted the folks that had the lower demand elasticity values. And so that seems a little counterintuitive, because aren't the more inelastic people supposed to be less sensitive to things? What we think this represents in some work that we're doing now, unfortunately, I don't have data yet to show. We're in the process of doing this with Matt Field over in the UK, is this value-based decision-making framework of thinking about the decisions that are made in the environment, and the fact that folks that show relative inelasticity to price are probably on this precipice or this state where that one little thing is the tipping point for a drinking event decision. In a value-based decision framework, their drift rate is probably quicker, and the point at which the response threshold is much lower. Fortunately, I don't have too much to talk about with that today, but be on the lookout for some full data in that regard. So to bring that full circle, when we think about this kind of step-wise way of thinking about informing public policy, with the research we do in the laboratory, we think about non-human laboratory research, human laboratory, clinical or field or observational research. These together leading us to an understanding of this easily explained and translatable language of econometric analyses of behavior and of decision-making that can then be fed up into any sort of experimental or simulated research we do, that then can be fed to policymakers and those that can influence policy, things like happy hour drinking specials, getting feedback from stakeholders and policymakers along the way. I have just a few seconds, so I'm going to hop on a soapbox for a couple of minutes about this research that we do in the approach to demand curve analyses. I'm going to talk about two things. The first, concurrent schedules of reinforcement, and the second, leverage the behavior. And this thinking is really informed by conversations and input and kind of late night think talks with Josh Beckman. Josh is out at University of Kentucky, where I did my graduate training, and we talk about this stuff. We talk about this stuff with some regularity. So concurrent schedules, what do I mean by that? So I mentioned a little bit earlier about how the value of a good or the decision-making around a good is dramatically impacted by the alternatives that are available in the environment. And I gave a little bit of an example of that. I'm going to give one more example that's, I think, a little more dramatic, though. So this is some work that we just recently published, going back to that social context, those social context manipulations. And so what you're looking at in the red circle, or at the top line here, is cocaine when it's available alone. Here again, cocaine when it's available alone. And then the same commodity, cocaine, when there was a concurrently available social drug-free partner. So animals could press on a lever and receive access for a short period of time to a social partner. On the left here, you're looking at the decrease in cocaine self-administration and this full cocaine demand curve when the social drug-free partner was concurrently available. Now, in contrast, if that social partner had been injected and had received an injection of cocaine just before the session, this is what we see that demand curve shift to look like. So in one case, we see this dramatic decrease in cocaine self-administration, and the other we see essentially no change. And we see that reflected, for example, here in that demand intensity and metric. And I bring up this example because much of the research that we do is conducted on these single schedules of reinforcement. And we measure a commodity in isolation and don't understand its dynamic interactions and the impact that alternative behaviors and alternative reinforcers can have. And so we've talked about this recently in the context of a really elegant recent EMA study from out in Missouri, and how when we begin to think about these environmental alternatives, the conclusions we make from any understanding of a reinforcer can dramatically change. Again, nothing new for the behavioral pharmacologists in the audience, but these sort of procedures, I think, have perforated outside of that audience, and it begs, it is important to be said. The other thing I'll say just briefly is I focused a lot on price today, But when we think about the impact that dimensions of the environment can have, we can think about things like a delay, which is often conceptualized in delay discounting. We can think about the impact of probability, which is often represented in probability discounting. We can think about the impact of our social relatedness, something often referred to as social discounting. And it's likely that these things also represent, in a way, cost. And there's probably a more parsimonious and unifying and kind of reconciliation way of putting this all into understanding how these independently modulating reward dimensions, reward magnitude, probability, delay, are ultimately impacting behavior in a way that we're not necessarily doing now. And so folks have talked about this and thinking about different ways we can think about cost and constraint. Others, Steve Hirsch, as well as Mickey Coffernus, I don't have the paper up here, have been thinking about the ways in which demand or discounting might explain time, cost, or monetary costs in more meaningful ways. And so I think as we advance this field, an important thing to think about is how we can put this under a more unifying umbrella to ultimately inform how these different things are interacting in a relevant way. And so many people to thank, a lot of great people I get to work with across these institutions. I talked about much of the research with them today. Funding support for this work from NIDA, as well as some from NSF, primarily during my graduate work. And I have my contact info here if you want to chat with me after the talk. I went a little bit longer than I expected, so hopefully enough time to answer some questions. But feel free to reach out if we run out of time. And thank you all for coming today.